There are over 10,000 critical care survivors who leave hospital each year in North West London, and across that group we know this group will increase in number, and there's a real question around what's our role in primary care and what's my role as a GP and others around how we can look after them better as they leave the hospital. As a general practitioner, I see lots of different conditions, and intensive care has to be one of those areas. Thinking about my own training, I've only had very little exposure to. For many practices across the country, we look at the top 2% of people who are most at risk and think about how we look after them better. And critical care survivors fit perfectly into this group. If we look at the evidence base, they benefit from holistic, proactive care, where we look at their physical, their mental and their social care needs in that initial care planning appointment. The second step of that is our ability to be able to recall them and review them, and to access further help from a multidisciplinary group, which many areas have set up, like North West London. When we are stuck within primary care about what to do, instead of sending the patient around, we have the opportunity to seek that advice and bring it back to the patient so they benefit the most at a time when they're least at need, so we can look after them better.
The majority of patients who are cared for in intensive care units stay for short periods of time, for maybe 2 to 3 days. But many do in fact stay longer. A significant minority stay in intensive care units for substantial periods of time. And a significant minority of patients who've been in intensive care have significant challenges on their roads to recovery. But if we get our systems in place properly and we identify problems for patients in an organised way, then we should be able to put in place help which will allow them to recover to the best possible quality of life. We have a mixture of reasons for admissions. Significant numbers of people have major surgery, and now often a period of post-operative intensive care is routine for these. And we also have people who are admitted because of emergency medical or surgical conditions and of course trauma. And increasingly we're seeing people who are surviving very severe myocardial infarctions or cardiac arrests who we are successfully treating within our intensive care units and sending them home. And of course now we have hyperacute stroke units. So a whole variety of different conditions are treated now in intensive care units for periods of time. What we've learned from talking to very large numbers of survivors of critical illness is that many of them, when they get home, they experience something that might be called a honeymoon period, because they're so glad to be out of hospital and so glad to be back at home with their families. But then as they start to attempt to rebuild their lives, they start to appreciate what the challenges of their recovery are going to be. Not surprisingly, many people who've been in intensive care units have suffered difficulties with their body, with their organs which have had to recover from perhaps failure, and also their joints may be very stiff and they may have scars which can be uncomfortable. And strikingly, people have difficulties with their skeletal muscle. And what we've learned from recent research is that for many people, they can lose up to 1 to 2% of their skeletal muscle mass each day for the first 10 days that they're in the intensive care unit, especially those patients who've suffered significant infections. So there's no doubt that many people have a battle with physical symptoms when they're in recovery. What we've also learned is that for many people, they have non-physical consequences. And these things can range from anxiety, depression, sometimes as far as post-traumatic stress disorder.
I was in intensive care for 4 months. I was in a sedated coma for 6 weeks, and in all I spent some 9 months in hospital. The memories of intensive care are vivid. We have, of course, the hallucinations that one has when they give you those drugs, and your mind goes absolutely balmy. And you have these dreams that are incredibly real but cannot be real. I remember all the nurses, I remember the conversations. many things. Generally speaking, one is traumatized to the nth degree with this whole thing. I think they call it intensive care psychosis. Well, I've had plenty of that, and plenty of post-traumatic stress disorder as well. In fact, I'm probably barking mad, but I manage.
We know that the challenges that some patients can face can be complex. So as occupational therapists, we are involved with these patients from an early stage within the critical care environment to address some of these issues. Within the rehabilitation team, we make goals with the patient to enable us to complete goal-directed therapy to help them to achieve their day-to-day tasks. In the community, the occupational therapist will continue this with both cognitive and physical rehabilitation, as well as looking at the home environment to make any modifications that will facilitate the patient's independence. Independence can mean different things to each patient depending on the tasks that are important to them. This can include managing sexual dysfunction, managing continence, a problem scar, or returning to work or school. Early identification and goal setting with each patient is crucial in the care planning process.
We've recognised now that patients who've got long-term conditions have significant psychological comorbidities, and that if we don't treat these psychological comorbidities, actually the long-term conditions themselves have worse outcomes. I think the same we now increasingly recognise is true for critical care survivors. In mental health services, we're really used to this concept of a recovery model. The recovery model goes beyond the pure recovery from the illness that the patient is describing, but actually incorporates recovery in a much broader sense. We might think about patients' psychological recovery, that is to say their ability to cope with the aspects of their illness. Or we might also talk about their functional recovery, not just the return of the function of their body following the illness, but thinking about the return of their function in a much more broad sense, including their relationships with their loved ones, with their families, but also the relationships with their work colleagues, perhaps being able to return to work. In applying the recovery model, it's really crucial to have the patient at the centre of our care plans, but we really need to draw upon the resources from carers, loved ones, family members, and also the whole multi-professional team that might be around the patient.
Some people have particular challenges with their cognitive function during recovery. And this can range from simple difficulties with remembering things to more complex challenges, such as doing the sort of mental tasks that we all take for granted running our day-to-day lives. We must remember that for those survivors who are experiencing a significant challenge in recovery, their families often experience a very significant change once the patient gets home. Many family members become involved as informal caregivers, and they have to make adjustments to their own working and professional lives. Some people may retire early, some people may have to reduce the amount of hours they work, others find that they lose their jobs completely and end up dependent on the benefit system, and often they find negotiating the benefit system very difficult, and finding adequate advice for that is sometimes a really difficult thing for people to engage in.
The GP's role in one's rehabilitation is absolutely vital, and that's why they need to be kept fully in the picture by the intensive care unit and the ward and the hospital as to how their patient is progressing, so that when the patient comes out onto the street, into the community, the GP is there to help them set their goals for rehabilitation and look after them.
Building on existing processes, we have developed pathways to facilitate communication of important information about survivors from critical illness to our colleagues in primary care. What seems fundamental is that when primary care colleagues are planning the future care and rehabilitation of patients who've survived in critical illness, is that they do this with the best available information.
For all our patients who survive critical illness, for them and their families, survival is simply the first step. As they come out into the community, our role within primary care is to offer them proactive, holistic care to help keep them as well as possible for as long as possible.